The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. This is Deanna Mitchell from Leading Age Michigan, and we are gathered again this week to discuss the latest pandemic issues for long-term care and post-acute care providers here in Michigan. It's been a little over a month now since the shutdown began, and while we have seen some promise in recent caseload numbers, we know that the epidemic is really beginning to show up in many, many nursing homes across the state, especially in Southeast Michigan. We can't say enough in appreciation for our members who are really serving in the most challenging areas. They serve the most vulnerable populations, and you're doing so with staffing and equipment shortages, so we know how intensely hard that is. It's our goal to help you all in any way that we can, and this webinar is just one way we hope to clarify issues, obtain some input and feedback about what's going on in your individual communities and how we might assist as this thing continues to evolve. Next slide, Blake. Today we've changed the agenda order a bit. This morning we're going to start with an advocacy update, followed by a member story from Heritage about setting up a COVID unit in their community. And then we will end with caseload data and an overview of recent directives, similar to how we normally run the webinar this morning. We have, again, divided the content into segments and provided a short time for questions at the end of each of those segments. And in order to conserve time, we ask that you submit your questions during the presentation of content so that we are not spending a lot of time waiting for questions at the end of each section. So with that, I will turn the virtual podium over to Dalton Kerbel, our Director for Advocacy here at Leading Age Michigan. Dalton.
Good morning, everyone. And I certainly want to pass on my thanks and the appreciation of everyone in Lansing. I keep hearing from so many different individuals associated with the Lansing scene that they're very proud and thankful of the work you're doing. So thank you. Next slide, please. Just to reiterate a couple of things last week and to provide just a very quick update on what our initiatives are currently. We're currently working on legal immunity for healthcare providers, workers, and residential communities for their response to the declared state of emergency. We've gotten some feedback on that, and it's currently working its way through the political system. We're asking about the equal distribution of federal FMAP funds for all healthcare settings. We're encouraging the governor, legislature, and the department to set aside the recommended October 1 reimbursement system change. The whole budget process, which you'll see in a slide, I believe right after this, has gone kind of haywire with the COVID-19 pandemic. There's a lot of extra costs associated, and it puts a lot of things in question in the go forward. And we don't believe that this change will bear fruit. We also advocate for removing restrictions on the CMP funding pool. This will allow us to better offset costs for COVID-19 care expenses. We've received a lot of positive feedback about this one, and people are looking into it for us. Next slide, please. Once again, a quick budget update from the department and legislative officials have been projecting about a $2.5 to $3 billion shortfall in the state budget as a result of the pandemic. This was a massive shortfall, obviously, and they're going to be expecting to have to make difficult decisions in the go forward. The other day I heard they were considering laying off non-essential state employees, which, yeah, that's a pretty drastic step in the short term. On Monday, the Senate Fiscal released its monthly fiscal report for March, indicating that state tax collection was down $80.8 million and collections in general was down $148.4 million. They also indicated that this doesn't necessarily reflect the data they're seeing regarding the COVID-19 results, and that this is just kind of the start of the bad news, so to say. The leadership are remaining, legislative leadership is remaining hopeful for the potential of federal aid coming. I know that some of you may have saw on the news that the unemployment system is getting really heavily taxed right now. There's about 1.8 million Michiganders on unemployment insurance right now, and they're expecting worst case scenario holds that Michigan will be out of unemployment funds by mid-July. And that's coming from the state, which is Michigan, that had the fourth largest unemployment insurance pool in the nation. So they're hoping for some federal aid there. I know there are loans that you can get through the federal government that states can get for maintaining their unemployment systems, but nothing has been set in stone yet as to what they're going to do about that. Once again, while we believe it won't come to pass, the removal of the executive budget recommendation to create that new reimbursement system for skilled nursing facilities by October 1 still looms out there, but we don't think it'll come to pass. So one thing we have gotten from the department and Leading Age Michigan and the Medicaid director, Kate Massey, have been working very closely on this issue. MDHHS has offered the following in support. We got $15 million in advances for future Medicaid settlements, $27 million by providing a 30-day extension of your April provider tax payments, $5 million in upfront lump sum investments into the COVID-19 Regional Hub Initiative, which we'll be talking about shortly here. And 30 days, the state has agreed to a period of 30 days to review and analyze cash flow needs. So kind of going on to regional hubs, MDHHS has been planning for COVID-19 care. We're working very closely to support existing and potential COVID-19 member units. A couple of things that MDHHS has been looking for. They've been looking to research the possibility of setting up care hubs on a regional basis, assisting providers in providing and delivering PPE, develop partnerships with the Department of Public Health, and work with DTMB, the Department of Technology Management and Budget, and the state treasurer to ensure adequate compensation. And current discussions currently include a cash infusion with per bed funding and a lump sum advance to get started on this regional hub project. These hubs could interact with regional centers, hospital care centers, long-term care settings, and we consider liability to relief for these settings to be of utmost importance, and we're currently working with the state Medicaid director, the director of LAURA, to determine the quickest way to stand up and reimburse both licensed and unlicensed alternative care sites in Michigan. So this is right here on the right, or your screen, I believe. You'll see the map of the regions that have been set out by MDHHS for these regional hub sites. Leading Age Michigan and the other provider associations such as HCAM and CMCFC have been working very diligently with the department. You'll see there's 5 regions, and the intent behind these is to cohort positive residents on a regional scale to preserve PPE and provide adequate funding for COVID-19 care. So how is this implementation of these regional sites going to work? The program is not set in stone. It's very much a flexible program, and it's going to roll out in phases, with phase 1 focusing on Southeast Michigan and Detroit because of the massive number of COVID-19 cases down there. Hub providers have been selected by MDHHS from the association survey data that we sent out earlier. Currently, there are 18 providers in Region 5, which is that Southeast Michigan, Detroit area, and 1 or 2 in all other regions. They've really tried to stand up that phase 1 or Region 5 section first, and they'll stand up the other sections as the need arises. The department, as I said, the department plans to extend or contract the program as the need rises and falls, and they're seeking, the department that is seeking to have this process codified in an executive order here soon. What are the benefits to becoming a hub provider for your region? So from the last budget supplemental, $5 million was taken out of that and allocated to this regional hub program. This offers providers who are selected as a hub provider $5,081 per COVID bed as a lump sum payment and startup costs. And there's also a potential to add up to $200 per COVID bed on your Medicaid rate to help care for those patients and residents. Not only that, but the department will work closely with these regional hub sites to provide them with adequate PPE from the Department of Public Health's PPE supply pool so that they can adequately supply and maintain proper protection and care for individuals in these settings. If you are interested in becoming a hub provider, especially if you are in one of the regions that is not Region 5, those regions with 1 or 2 providers, please contact me. You can see my email on the screen and we'll get you that survey. Once again, this program is not set in stone, so there's no guarantee that this program will expand out of Southeast Michigan. But as COVID-19 spreads across the state, we'll see this program becoming more and more important in those other regions. Any questions for me before we move on, I believe, to a member interview?
I do not have any questions so far, so we can always give it a second, see if anybody is typing anything. But thank you to Dalton for all that information. That was great. I am not seeing any questions come through, so Deanna, if you'd like to take it over, feel free.
Thank you all.
Sure, thank you, Dalton and Blake. As Dalton has said, MDHHS, the department is putting a lot of focus on ensuring that there's access to care for COVID patients who might need to be transferred out of the hospitals in order to free up hospital capacity, or who may not simply be able to cope with the virus infection if they're at home. So a lot of discussion has been centered around the need for alternative sites for care, and also ensuring that we can protect patients by cohorting both infected and non-infected seniors. So this morning, we have Paul Barber from Heritage Community in Kalamazoo and Andy McLeod from GMB to give us some information about how they have developed a dedicated unit for COVID positive patients at Heritage. So I will turn it over to Paul and Andy. Welcome.
Thank you. Good morning, everyone. I'm Paul Barber, and I'm the Vice President of Operations at Heritage Community and the Incident Commander for our Emergency Preparedness Response to COVID-19. And I'm pleased to be here today to share what we've done to set up our isolation and treatment unit. You can see on the screen there. Heritage Community is a senior living retirement community with separate skilled nursing, assisted living, memory care, and independent living on our campus. And we serve over 350 residents, have more than 400 staff members. Today, we have no cases of COVID-19 on campus. As we've worked through our preparation, we identified the need to develop a strategy to keep our staff and residents as safe as possible in the event we were to have a case. We decided to focus on our training, PPE, and expertise into one location and started developing our isolation and treatment unit. The idea was to convert a wing of our skilled nursing facility, the Upjohn Care and Rehab Center, into that unit. It really started with an idea from our CEO, Jay Prince, and a weekend brainstorming discussion. Within a week, the physical plant improvements were complete. And to make this happen, we partnered with GMB, Architects and Engineering, Miller Davis Construction, and RW Lapine Mechanical to very quickly design and build out the improvements that resulted in this unit. Andy will describe this in more detail shortly. Concurrently with that work, our administrator, DON, housekeeping supervisor, medical director, and I developed criteria, protocols, equipment lists, and refined the flow of people and supplies through the unit. With that, I think at this point I'll describe the flow through the unit and some key points. So if you're looking at the screen, you can see in the upper left-hand corner where it says staff and there's an orange arrow. That's where our staff and our residents will enter the unit. And that is a dedicated entrance that is exclusive to the unit. And we have a one-way flow of people you can see with the orange arrows. Those are how people will flow through the unit. So they enter that blue clean area of the corridor and then enter into the transition area, which is also a clean area. And in that area, we've dedicated a resident room for staff to utilize to decompress and or get ready to go into the unit. We also anticipate at shift change having a manager there to provide education and feedback and answer any questions to our staff when they get ready to go into the unit. Also make sure that they have their PPE on correctly. Staff would then transition through into the next colored corridor area through a door that was installed and a wall that was installed into our isolation unit, which actually will have 9 rooms initially set up as private rooms, but they could we could flex them into semi-private rooms if the need arose. And so our staff would then be in that same area where there's the corridor and it says nurse on that area for the entirety of their shift. We have this, assuming that our COVID residents would be, our residents with COVID-19 would be in their rooms, this common area down in the middle of the unit where it says nurse would be for staff to take their breaks and or make sure that they have everything that they need. As the shift ends, staff would then flow out into this, it's actually a courtyard area. It's a contained courtyard where it says decontam tent. And in that area, staff would take off their PPE, would sanitize their hands, make sure that the soles of their feet are sanitized with sanitizer, and then they would move across the courtyard and then move back into the back part of the hallway where there is a clean area. We have lockers installed there, and there are bathrooms there for staff to then change into clean clothes and move out a separate exit to go home. The other flow would be flow of food, supplies, and equipment, and those would come in from the bottom, the rest of the building, and those would be delivered into this blue area, and those items would be put into a transition room where we have a table or countertop. Staff would reach in, set them on the countertop, close the door, and then staff from the unit would then reach in from the other side, pull those items through, and be able to serve meals and have extra supplies come into the unit in that direction. Trash and linens and things of that nature would also flow through that decontamination area in that one-way flow and would go into barrels. Those barrels are then sanitized in the decontamination area in the courtyard and heavily sanitized according to our protocols, and then would be moved into this back hallway where they would then transition to another barrel in the corridor that's not highlighted there, and then they would be cleaned. Those barrels would then be cleaned again, and then they would move back into our either laundry for linen services or out to disposal for trash. So that's kind of a brief overview of and some of the key points. While we've worked through all the aspects of setting up the unit, the final piece is staffing. And as I think we've had other discussions about even prior to this call. So we've initially started with a call for volunteers from our staff, and we have had some good response. We are offering a initially a 25% pay increase, but we're making sure that we're being consistent with what the market will bear. And we've set high staffing ratio, essentially double what is on our rehab unit, starting off with 2 care staff, a nurse and a CNA, and then moving to up to 7 staff if we have the unit completely full, including a housekeeper to bolster our sanitizing efforts. We have had a number of CNAs that have raised their hand and volunteered. We actually also have a CODA who is also a CNA volunteer, which will allow us to provide some therapy to our residents with COVID-19, but we're still focused on getting some nurses to volunteer at this point. So with that, I will now turn it over to Andy, and then I'll stay on and be available to answer any questions.
Good morning, all. So as many of you know, I'm an architect. I'm not a mechanical engineer, but I'll do my best to explain what we're doing. So if you can hit the next slide, please, Blake. Sorry. So with the with isolation in general, you know, there are 4 approaches. So you can dilute the air and bring in as much outside as possible. You can exhaust the air and filter it. You can filter it within the room or inside the unit, or you can deal with pressure relationships. And so when we're designing something new, dilution and filtration are much easier. But when we're dealing with an existing unit, everybody's going to kind of end up with dealing with pressure relationships. And so we work from the cleanest areas, which have the most pressure, down to the resident rooms, which have the most exhaust. And really, we all know that we're not going to meet the SNF isolation or the hospital isolation. And it's kind of a do the best you can with what you have. And so, you know, we think that whoever wants to do this is probably going to land in the pressure relationship. So we're focused on that a little bit. So with this, we blocked off some exhaust in the positive areas, and we increased the exhaust in the resident rooms, and opened as much outside air through the fan coil units as possible in the blue areas, or the most positive areas. So it's really just getting into the details with the team, and that team for this was, you know, Jay called on Sunday night, and we started talking Monday afternoon. And on that call was, you know, Heritage's leadership, their facilities director, their HVAC specialist, and then we brought on the HVAC contractor, the RW Lapine, who does a lot of their work, and brought them into the conversation immediately just to see what limitations we may or may not have. And then we worked with Miller Davis, who works on campus, to install a few doors and a few walls, and create a few transfer grills and stuff like that. And so this was an amazingly fast development. So from Sunday night, we had it into the state on Tuesday afternoon, and they started construction Wednesday. So, which leads me to the state, who has been unbelievably wonderful and supportive in this. So our first call was the BFS and shared the plan and the idea, and their response was very positive, just as long as we were maintaining the egress and being smart about it. We also talked with HFES, and they were along the same lines of, you know, do the best you can with what's there, and we understand that it can't meet the standards. And neither of them took any action other than wanting to be informed. And then we talked with licensing, who also, Andrea was magnificent. And there are no new licenses or new beds on this for this project. So she said, well, you know, I want to know what's going on, but beyond that, we're in emergency mode, and just do the best you can. So really, I can't understate how wonderful they all were to work with. And we got calls back or conversations same day or next day with all three of those entities. So, next time you run into them or talk with them, thank them again. So the last thing on here is that, I don't think anybody's really figured out exactly how to sanitize the rooms in between patients. And it's not just the normal surfaces that you're trying to sanitize. We're a little bit concerned about the unit ventilators and how those all work. So there are some people working on that, how to use UVC or peroxide fog to sanitize, but it's still a little bit up in the air for everyone at this point. If you can switch to the next slide, you can see a couple of, it's just a little bit bigger. Sorry, I should have indicated that earlier. You can see, the pressure relationships are the pluses. So the resident rooms are negative to the nurse area and corridor, which is one less positive to the two ante rooms, which are less positive to the corridor and the delivery area. So it's just really about working within those existing confines to try to make this as good as humanly possible. So we had the easy part. We didn't have to deal with getting staff on board and finding staff to make this happen. So thank you to Heritage for that. And thanks for the opportunity to talk about this. And this is really quite fun for our mechanical engineers and I to just dig in and try to figure out on the go. So thank you all for that. And with that, I have nothing further. Are there any questions out there?
The only question that I have is, where is this location?
This is in Kalamazoo at Heritage Community. And this is about the center of campus.
All right, I believe that was the only question. So thank you.
I have a question for the group. I'm wondering, are there a lot of COVID positive patients in your immediate community, and are there other centers that are taking them? I'm wondering what you anticipate in terms of your volume of residents that will need this sort of care in the Kalamazoo area.
Well, I can certainly speak to that. We are aware of other cases at other communities. I think the previous discussion about the hub in our region, I think that is one of the communities that's currently a hub in our region that's accepting those COVID-19 patients. When we approached this, we realized that Heritage has a unique population here in Kalamazoo, and that our focus was to make sure that we were able to meet the needs of all of our residents, because we knew that if a resident were to go to the hospital diagnosed with COVID-19 or be diagnosed on our campus with COVID-19, that as long as they're not in that critical phase, that they would need a place to go to be cared for. And so that was really our focus, is looking at our population here on campus, over 350 seniors, and making sure that we were able to accommodate them. Our anticipated volume is really day by day. We think that we can start here, and then we're also working on, this is Plan A, but we're also working on Plan B and Plan C if things were to continue to develop here in Kalamazoo. So hope that answers your question.
All right. So do you have an anticipated date? I heard that, you are obviously dependent on staffing, but do you anticipate opening the unit soon? We
do. We anticipate being ready to accept residents very shortly. We're still reaching out to individual staff to make sure that all of their questions are answered and ensure that we actually are prepared to accept residents. We think everything else is in place except for that staffing piece.
Well, I want to thank you very much for this summary. I mean, I think it's an amazing amount of work and very thoughtful. I know a lot of our members have asked, like, what are the steps to set up a unit within their facility, and some are also thinking about setting up off-site units. So knowing that there are members out there that have worked well toward this is really outstanding. So I thank you both very much. Any other questions, Blake?
Yes, I did get a question. What kind of costs are associated with doing this kind of a project?
So the costs that we have incurred to this point essentially are the cost of working with the contractors and setting up the, I would say 1, 2, 3, 4, 5 walls and ordering a tent. So there are really minimal costs for our particular physical plant. I think it's relatively speaking. We looked at it from the standpoint of what would it cost to have to provide care and services to residents across our entire campus if we were to allocate PPE and try to do training on the whole campus to care for COVID-19 residents. Found this to be a much more viable and cost-effective endeavor. Now, we are also very blessed to have a strong foundation that has worked with donor organizations in Kalamazoo to provide some of that funding to offset some of those costs, and so we're very blessed to be here in the Kalamazoo community and have a very giving, supportive community around us. And
I'm going to add one thing. Oh, sorry, go ahead, Paul.
I was just going to mention real briefly, please feel free to share my contact information with any of the members. I'm happy to provide more detailed information. I know we just have a short call.
Great.
Yeah, I just wanted to add too that we looked at, there are a couple of solutions that could have made this even better pressure-wise and relationship-wise. But if you're out there trying to get mechanical equipment, you're going to have a bit of a tough time. So one of the things that we were really aimed to do was to not buy any new equipment to make this happen. So that certainly kept the cost down as well, and the timing.
Okay, well, thank you. We will now move on, Blake, to some of the data that we look at. We do continue to look at the data every day. We want to get the best understanding that we can about how the virus is spreading in the state and how it could potentially affect our members. So this next slide includes a map, and I've used this map before, and it's updated as of the 14th, which is yesterday, to show the pandemic spread across the states. And if you were on any of the previous webinars, you will know that it's a lot darker than it was in the beginning. And it's kind of important to note that there are only a few states left with low case numbers, and there are no states that don't have some COVID cases at this point. And unfortunately, Michigan has been toward the top of the list of states with high caseloads. We were at number 3, I think, last week. We are now number 4. I think Massachusetts has gained one level above us, but there's still an awful lot of cases in Michigan. So here are the updated national numbers, and I've reduced them to a weekly basis because I was running out of graph room. And of course, the caseload has exponentially increased over this month. And these are national cases, by the way. The total number is nearing almost 600,000 across the states. So next we have a graph of daily new cases. And one of the things that I find remarkable is that the U.S. numbers in many areas are so large compared to other countries. I think we have to account for the large amount of travel and business connections that Americans have, and we are a pretty highly populated country. But and we're also not sure that all the other data is accurate. But it's still a little alarming to see that our daily new cases are so much higher and have been higher than almost any other country. So we do have some good news here that the average daily new case rate obviously has taken a dive in the last few days, but it's not likely to go down in a straight line. So, it's going to fluctuate a bit as we move on, but it's possible that we are beginning to see the good side of the whole pandemic. So I've included a few maps here just because, as I said, it's kind of disconcerting to see the U.S. to be at the high end of most of the measures that they're looking at. Here are the cases per million persons, and you can see the really dark areas are the ones with the most cases, and they tend to be the most industrialized and populated areas, but the United States is still right at the top there. The next map is a graph of the daily new confirmed cases, and again, our numbers are toward the top. This next slide is a graph of the U.S. reported cases for testing, confirmed, and deaths. And if you look at these, you'll see that almost 3 million tests have been given as of yesterday, and of those tests, 19.4% were found to be positive, and 4.1% of the positive cases resulted in deaths. So we are at we're almost at 24,000 deaths across the nation, which is very, scary and horrendous. For Michigan, this is a similar map. You'll see that compared to some of our other states, we have not provided the number of tests that have been given elsewhere. So of the 82,000 tests that were given, and this is as of Monday, 25,000 were confirmed positive cases, and of that, 6.24% ended in death. Now, that doesn't necessarily mean that the situation in Michigan is that much worse. I sometimes think that because we only test people with strong symptoms in the beginning, that indeed our numbers are going to be higher. We might have more people in the community with less symptoms that would deflate these percentage numbers. But just looking at them on the surface, it looks like we have a little bit higher death rate, a little bit higher positive rate for the tests given, but you can't really say that because you still don't know how many people are out in the community and undiagnosed. So this is the Michigan new death rate reported per day in Michigan. As you can see, we peaked I think it's like last week. And as of April 14th, yesterday, we had a little bit of an uptick again. But then again, if you look at just the trend, it is still going down. And that is basically a good sign if it holds. And we'll have to see how that plays out over time. One of the challenges that we note, both across the nation and I fear in Michigan, is the high rate of infection in our healthcare workers. I think last week someone alluded to the morbidity and mortality weekly report numbers, and this report I saw was published yesterday using data through April 9th. And knowing that the data is incomplete, they identified basically that over 9,000 healthcare workers in the U.S. have been known to be infected. Most of them who are infected are early middle age, mostly female, and many had an underlying condition. 90% of them, though, were not hospitalized, and that's kind of a good number. Experts suggest that when reporting is better, for states that the reporting is better, healthcare worker percentage of all positive COVID cases hovers around 11%. But it's really a challenge and scary to our healthcare workers to be in this situation. So one of the things that's so hard and so important at the same time is how to support our staff, both direct and non-direct care workers, as we trudge through this pandemic. We know that many are scared and it's hard to figure out how best to help. The CDC does have some guidance, and Leading Age has put out a lot of resources about staff support, and we will be updating our website with a lot of those templates and support ideas later today. I went through them. A lot of them look very, very helpful. However, it is really a difficult situation for our healthcare workers to be in as we think about how short many of our facilities have had to work, and the additional challenge of a workforce that is really scared and having difficult time coping with the realities of the virus itself. We do have a call this afternoon with the department about to discuss staff shortages, so hopefully we will hear some good ideas and discuss how to address some of the areas. I know that some of our facilities have significant shortages at this point. So with the small decreases in caseload growth that we've talked about a little bit, and note that we still have growing cases, but it's the amount of growth that's decreasing each day, or most days. The caseload itself continues to go up. But there's been a renewed discussion about reopening states. And in a Monday press conference, the governor stated that she's working with 12 other governors, and I'm assuming that they're, close to us in proximity, to develop a safe plan to reopen the state. And she hopes to have that plan together by May. She identified a set of criteria, and I guess decisions will be based on these kinds of issues about the level of spread, medical and equipment capacity to serve, testing capacity, how well we can trace the virus, how well we can provide a safe work environment, and of course the economic situation in the state. Yesterday, Governor Newsom from California, you can move the slide, Blake. Governor Newsom from California put out a little bit more refined, but the topics were pretty much the same. So these are the criteria that California are going to use in order to reopen the state. And it feels like, although there's a lot of pressure to reopen all the states at this point, that we have a long way to go before we know that we have access to testing, we have the ability to trace cases, we have the ability to effectively isolate people and so that they're not exposed, and that we can ensure that we have enough healthcare capacity and capability to deal with the situation. So, but these are a very similar set of criteria that California is using and Michigan will be using to determine whether or not we should open the state. But one thing that I think that is an important thing to remember here is that this is the 20-80% iceberg that the University of Michigan has put out. And they put this out in particular response to the COVID piece, is that the upper part of the iceberg really only accounts for the cases that you know. So even though if you're on the downward slope of those cases, you still have to remember that 80% of the cases are in the community and are infectious. so that even though it looks better on the surface, it doesn't necessarily mean that there isn't a lot of risk out there yet. So any questions about the data?
I have not had any new questions come in so far.
Okay, well, since we're moving a little bit behind, why don't we move on to resources? And if there are questions about the data, which there are often not, we can catch them later. So the number of directives overall have slowed down in the past week or two, but that doesn't necessarily make them easier to understand. And unbelievably, they tend to come out in the late afternoon, early evening, lots of times. So as Dalton mentioned, there are several avenues of financial support from Medicaid, and there's also some Medicare programs that we have briefly discussed. The first is the Paycheck Protection Program, and that has been funded through the CARES Act. It is a forgivable business loan for entities with less than 500 employees. You can move to the next slide, I think, Dalton. So you can apply for up to 2.5 times the monthly payroll. You can go back to February 15th in determining what your monthly payroll is so that you can capture employees that might have been laid off. The maximum loan is $10 million, and members must go through their current bank. There is a Michigan website through the Michigan Small Business Association that carries the details and is meant to help small business providers. In addition, the 2% sequestration will be suspended from May 1 through December 31. And that can be a chunk of money for a lot of our members. Unfortunately, they're just going to add months on to the end of the sequestration period, but it is something that's helpful right now. Another thing are advanced Medicare payments. We talked about these a little bit before. Members can contact their MAC in order to get advanced payments, and pretty much those payments have to be paid back within 210 days based on your submitted claims. They will, decrease your payments based on submitted claims, and all of it must be paid up back in 210 days. But the really more positive approach the CMS has taken is our grant monies that come from the CARES Act stimulus funds for provider relief. These funds started to be dispersed this week. I don't know if any of the members have gotten these funds yet. They are based on Medicare revenue for 2019. So this is pretty much only for those with Medicare fee-for-service revenue. The total amount for this first phase was $30 billion. It's based on Medicare fee-for-service payments in 2019. In order to estimate your grant, if you take your payments and divide them by 484 and then multiply by 30, you will know how much money you should be getting. There are some things that you have to agree to. There is an agreement that you have to sign. The agreement comes later after they give you the money, oddly enough. You cannot seek collection of out-of-pocket payments greater than in-network co-payments would be. Leading Age reported yesterday that a lot of providers were getting the wrong payment. A lot of providers hadn't gotten payments yet, which is not surprising to me. I think it's going to take a little bit of a while, but people who have questions about this or about how it's working or whether or not their payment's accurate, there's a website, Hospital COVID-19 at hhs.gov, that members can access. So, blanket waivers. We all know that there was a long document put out not too long ago, maybe a week or two, that included a whole lot of federal blanket waivers. A couple days ago, I think late last week, the feds updated a couple of those. One for SNFs. There were updates to other areas as well, but for SNFs, PASAR, they put some detail in this to include that you don't have to have a level 1 screen done before admission. You can do it after admission, but by the 30th day, if you do have anyone who has mental illness or intellectual disability, they have to be referred by the 30th day for a level 2 review. Physician services, they clarified that physicians, there are physician-only tasks that are required in SNFs by rule. And physicians normally cannot delegate those tasks, but now they are allowing physicians to delegate those tasks to extender kinds of professional roles, but it still must be under a physician's supervision. The physician visits themselves can be made by extenders as long as they're not employees of the facility, and of course within the state scope of practice laws. Within the blanket waiver document, there was originally a discussion about flexibilities regarding long-term care transfers. A couple days ago, CMS put out QSO 2025 that clarifies what the transfers are allowable without approval. So basically they've said that 2 or more certified nursing homes can exchange patients as long as it is in response to a cohorting without any additional approval, and each facility would bill Medicare and Medicaid accordingly. Transfers, though, from a nursing facility to a non-certified location that's state approved, and that's critical in terms of the Fed's eyes. All of these alternative locations have to be state approved. And the assumption is that residents must be cared for by the initial facility staff. So you're sending someone to a place that is not been certified as an alternative, but it is an approved alternative care setting, but that you're also sending staff, and then of course reimbursement would remain with the facility caring for the patient. And last but not least, if there are federally or state-run facilities in the state, you don't need a waiver to approve any movement there at all. So those are some of the clarifications that have come out. A brief review of the executive orders, of which we have many. Basically, there are not any new ones, I think, in any of the categories that we're tracking since last week, except I would like to move on to the workforce slide. I would like to review again 2020-36. So if we move to the next slide, we talked about, these are the other EO slides, so I will go through those. They don't really pertain a whole lot. One more slide, Dawn, please. So we talked about 2020-36 last week, and I was remarking that I didn't understand the point of prohibiting from discharge or disciplining any employee for failing to comply with a requirement to document that they had been in contact or they have principal symptoms of COVID. What I want to make sure that we're clear about is that even though I don't understand it, the fact that we might wait a really long time before we get any updates or clarifications, and that members are still required to do all of the surveillance and all of the other monitoring of both residents and staff that fall under the federal rules. But on the face of this, I mean, you're simply not going to be allowed to discharge or discipline someone for not reporting to you. Again, it still makes no sense to me, but I want to make sure that everybody realizes that on the face of this, that's the rule. And right now, I guess we're just going to have to live with that. April 9th, the CDC put out the guidance for risk assessment of healthcare professionals with potential exposure. I'm sorry, let me go back. The CDC put out a memo called Implementing Safety Practices for Critical Infrastructure. And that April 9th guidance confused a lot of people because it talked about critical infrastructure people and when they can return to work, if they've had exposures, what they need to do. It didn't talk about healthcare people at all in any way, shape, or form, although we all know that healthcare workers are critical infrastructure people. And because what this new document was saying was far less detailed and had far fewer requirements for than for healthcare professionals, there was a lot of confusion about that. And CMS has confirmed that this April 9th guidance that I think that we got some questions about from members doesn't apply to healthcare personnel. So it is not anything that you need to pay attention to. And basically, you need to go back to the detailed guidance for risk assessment of healthcare professionals with potential exposure, which is on the CDC website. Michigan testing and reporting. There's been a lot of discussion about Michigan testing in the news in the last week or two. There has been a network set up called the Michigan C19 Laboratory Emergency Response Network. And they have been designed to coordinate the scarce resources, especially in terms of number of tests. They have created a provider hotline. If you have questions or issues, that is the number to call, and they do staff it for 12 hours a day. The guidance from the department is that all healthcare professionals should be tested. However, we all know that's not going to happen because there's a priority of testing because of limited test availability. So they have expanded their definitions a bit in the last couple days about what those priorities are. And these are all in alignment with the CDC guidance and the Public Health Service guidance that have already come out. So Tier 1 is for hospitalized patients, number 1. Healthcare employees with symptoms, number 2. And the clarification is that healthcare employees in this situation includes everyone who happens to be working in a facility. It's not just someone who does direct care. Any asymptomatic workers will not be prioritized, but they do suggest that they be monitored. Tier 2 are patients in long-term care facilities with symptoms, patients 65 plus with symptoms, patients with underlying conditions with symptoms, and first responders with symptoms. In other words, people with symptoms. If you don't have symptoms, they're not going to be doing any testing of the general population. There's a list of all of the people who are in congregate living arrangements that would fall into this category. And again, asymptomatic patients will not be prioritized. Tier 3, this is something new. The department did not have a Tier 3, although the U.S. Public Health Service had. And that would include critical infrastructure persons with symptoms, and those are people who are not healthcare workers, obviously. All of the critical infrastructure workers are defined in Executive Order 21. Again, you have to be symptomatic. There's no prioritization for anyone who isn't carrying symptoms. And it also doesn't include anyone who might be working from home. So, new rules about persons under investigation. This was a little complicated. So, and it's not necessarily conflicting, but there are rules for how you have to get prior approval, depending on what laboratory you use. So they no longer require prior approval from the state for testing, and no longer require a person under investigation form from most of the laboratories in the state. The only exception that I'm aware of is the Bureau of Laboratories. So if you go to the state to get a test done through the Bureau of Laboratories, you do have to get a PUI form. Medical providers who are ordering these testings still have to do so in line with those prioritization criteria that we just talked about. and positive tests have to be reported. Of course, that's generally not our job. That's the health department and the lab tests, laboratory jobs. The state has also put out a standard operating procedure interim guidance for reporting, and this has caused some questions and confusion for some facilities across the state because of the language in the second bullet. It says the list for mandatory reporting of deaths in Michigan has been expanded to include COVID-19 for those within 24 hours of identification, consistent with Michigan communicable disease rules. So, and that rule requires that within 2 hours of a death, health facilities must contact the local health officer to inform them of a COVID death. So even though there's this 24-hour thing up there of identification, you know, one of our legal experts says you have to report a COVID death within 2 hours to the local health officer, period. So I just want to make sure that members are aware of that. Healthcare providers should deliver an electronic or fax copy of the patient's electronic medical record to the health department. And the health department is then required to investigate deaths for residents of high-risk facilities. And long-term care facilities are categorized like that. So you should be prepared for that. So that if there is an issue with the way things are being transmitted, they can address it. Deaths that are suspected due to COVID-19 but have no confirmed close contacts, but that are in a high-risk facility, such as a nursing home, might be investigated as well. Okay, so questions?
Do you anticipate this criteria to continue to change as testing evolves?
I anticipate that all the criteria from anywhere is going to change. And yes, I do think that eventually we're going to get, hopefully, to testing some people who are not symptomatic so that we have a sense of maybe immunity and how widespread the bottom part of that iceberg might really be.
Okay, and then this said, just an FYI, in regard to the PUI number, they will need to check with the lab they use, as our local hospital runs our labs, and the COVID swab is sent out to Mayo Clinic, who does require a PUI number along with the PUI paperwork, even though the health department does not.
Oh, okay. Well, good to know. Thank you.
I do not have any other questions other than that.
Okay, well, we'll give it a minute. Why don't you move to the next slide, because I have a few final things to talk about, and then we can see if there are any more questions. As you probably know, we do publish our member update daily, and we convene this weekly forum as long as there seems to be a need for information or clarification or discussion. We have redesigned our website a bit, which is, the link is there. There are topical complementary webinars that I want to make sure that everyone's aware of. And our next one is on April 17th. And it does include some LARA clarifications about infection control practices and regulatory guidance. And I think that's at 1 o'clock. So you can sign up from either the member update that comes out every day or the website itself. We do a daily update of the numbers. We are trying to create some summary documents that kind of puts everything together for you within a certain area. So far we have finished the CDC guidance for long-term care facilities, not just nursing homes. And it includes, in a little bit better flow, I would hope, information that everyone needs to know in order to serve our residents. We've also put together a section called Lift Up Through Leading Age Michigan, which is tools and templates designed for people to help each other We can put policies on there. If you have a great success tool or successful tool or a template or a policy and you want to share it, you can send it in to us and we will put it there for people to look at. And then, of course, we have information updates by other categories. So just to also let you know that last night, Laura, the Bureau, sent us an updated Q&A document for AFCs and HFAs. We have not had an opportunity yet to review that in detail. We will provide a review in this afternoon's member update. And also yesterday, HUD updated its housing guidance, and that will also be featured in this afternoon's update, just to let everyone know. So any other final questions, Blake?
I did not have any other questions come through.
Okay. Well, thank you very much for your time and interest, and I hope that you take the time to look at our member update. It'll have new information as I discussed this afternoon, and other than that, I'll talk with you next week. Thank you, everyone. Take care.